Good afternoon, everyone, and morning to those joining from West Texas and beyond. Thank you for joining us for this timely dialogue in recognition of National Diabetes Prevention Month. I'm grateful to see so many participants from across Texas and beyond, representing public health, healthcare, payers, community-based organizations, philanthropy, and the food access sector. Before we get started, a quick note that today's webinar is being recorded. Please feel free to submit questions using the Q&A option at the bottom of your screen throughout the session. We will address them towards the end. For any technical difficulties or requests, please use the chat option. Next slide. Today's conversation, Building a Healthier Texas, Innovations in Diabetes Prevention Across Texas, is truly a cross-sector and collaborative effort, and that's by design. This webinar is co-hosted with two of our statewide partners who are leading the way in connecting food, health, and community. We are honored to partner with Feeding Texas, representing the food access and nutrition sector, and Texas Association of Community Health Plans, representing the payer perspective. And our speakers through both of the sectors bring perspectives that are essential to the future of diabetes prevention. Their leadership and expertise reflects a growing understanding that meaningful prevention requires more than clinical care. It requires trusted systems, community reach, and aligned resources. Next slide. For those of you new, by way of introduction, I am Ankit Sanghvi, Executive Director of Texas Health Institute. At THI, our mission is to advance the health of all Texans through evidence, policy, and systems change. Our work is guided by the three priorities of advancing health system transformation, strengthening public health infrastructure, and promoting healthy communities. And today's discussion, focused on food, prevention, and community partnership, cuts across all three of these priorities. It is exactly the type of multidimensional challenge we were designed to help convene and illuminate. Next slide. We bring these priorities to life through four core strategies: research that is independent, data-driven, and actionable; translation to help partners understand what the data means and how to use it; collaboration, where we serve as a neutral convener across sectors and initiatives; and capacity building to ensure communities and systems have the tools, skills, and relationships needed for impact. We do this work with a statewide lens while also contributing nationally to conversations on access, public health infrastructure, and community-led efforts. Speaking of collaboration, and coming to today's discussion, our vantage point is strengthened through the networks we steward: the Texas Primary Care Consortium, the Texas Oral Health Coalition, and the Texas Rural Maternal Health Assembly. Across these initiatives, a shared insight is emerging. The future of prevention, diabetes included, depends on bridging clinical care, public health, and community systems in ways that make health accessible, trusted, and sustainable. And that brings us to today's conversation on diabetes prevention. Next slide. To ground our discussion, I want to begin with why diabetes demands our collective attention. It is estimated that as a state annually, we spend upwards of $34 billion annually, and that cost continues to go up. More than 2.8 million Texans have diagnosed diabetes. Another 7 million have pre-diabetes, and nearly 1 in 4 adult Texans with diabetes remain undiagnosed. However, as we know, diabetes is largely preventable, yet prevention and opportunities thereof are unevenly accessible. The biggest predictors are not simply clinical risk factors, but structural ones: food access, affordability, geography, transportation, and the environments in which people live, learn, work, and play. Next slide. In spite of these challenges, I think we are in this opportune moment where there is real momentum around diabetes prevention and truly tackling some of these connections or barriers that are inhibiting cross-sector efforts. At the national level, The administration has made chronic disease prevention and nutrition security core health priorities. In Texas, just recently, during the 89th legislative session, we saw a bipartisan effort with the passage of HB 26, giving Medicaid health plans, MCOs, flexibility to offer nutrition support as in lieu of service, an important step towards addressing systemic challenges. And then, most recently, about a couple of weeks ago, with the Texas application to CMS, the Rural Texas Strong Application or Transformation Plan explicitly elevates diabetes prevention, nutrition, and primary care access as foundational to long term rural health, sustainability, and innovation. These shifts and movements create an opportune time and a perfect time for alignment between policy, practice, systems, and community need. Next slide. And as we have this conversation, we know through our partners such as TACHP and Feeding Texas, across the state, innovation is already underway. From food banks integrating nutrition education and screening, to payers investing in food as medicine models, to cross-sector partnerships redefining what sustainable prevention looks like. And so the opportunity today before us is to understand what approaches are proving effective, what is working, for whom do they work best, and in what context? And how do we scale the solutions to reach communities across Texas? Most importantly, we also have to create spaces to learn from the leaders, such as thus joining us today, for who's already doing this work to keep this grounded in the realities of the many communities that call Texas home. And with that, it's now my honor to introduce my partner in today's discussion, Janet Walker, the President and CEO for Texas Association of Community Health Plans, to give an overview about efforts through TACHP and introduce our expert from the payer perspective for today's discussion.
Thank you, Ankit, and thank you to the Texas Health Institute and Feeding Texas for your leadership across the state in this area, among many other areas as well. And thank you all for being here today. I think you're going to hear some themes as we spend time today around relationships and partnerships, and THI and Feeding Texas are certainly a key part of that. I'm Janet Walker, President and CEO of the Texas Association of Community Health Plans. TACHP, as you might know us by, is an association of 11 community-based health plans representing all 254 counties across the state, representing more than 2 million Medicaid members across the state as well. As part of this work within our respective communities, we provide education and work with innovative community partners to improve the health of individuals and families in the communities in which we serve. As part of this work, I'm so pleased today to be able to introduce Dr. Carl Sorrell, who's the Chief Medical Officer with Driscoll Health Plan. Driscoll Health Plan serves 24 counties in the Nueces and Rio Grande Valley service areas. And Dr. Sorrell is a true servant leader. He has more than 25 years of leadership experience, and as his role as a senior executive with Driscoll Health Plan, he's responsible for health plan clinical, population health, and strategic initiatives within Driscoll. Today, Dr. Sorrell is going to be speaking about one of those initiatives in particular, the Nurture program, which is the result of partnership with many of you all on the phone today, Episcopal Health, UT, and UT Factor Health as well. And so really looking forward to the conversation today, Dr. Sorrell. So with that, I'll turn it over to you. And I know that this work is particularly close to your heart as well, given the rate of gestational diabetes within the service area in which you deliver care, which is 2.5 times higher than the national average. So with that, Dr. Sorrell, I'll turn it over to you for some introductory remarks.
Janet, hey, thank you so very much. I am so grateful to be here today and to be part of this webinar and addressing folks. Thank you for the nice introduction. I'm a pediatrician. I'm a pediatric ICU physician. And, a lot of my experience with diabetes has been, direct, meaning, taking care of patients, but I've also seen a lot of the effects as it has impacted families. And of late, a big part of my mission and passion has been addressing gestational diabetes with our maternal population, because this is what sets up not just these individuals for a lifetime, but also their children. Because our moms with gestational diabetes, those children are more likely to have diabetes themselves, more likely to have obesity, and those women are 50% more likely to have diabetes in the later on in the postpartum period. So for me, it's about making a difference then, because it has huge impacts down the road, and addressing food insecurity is a huge part of what we do, of what we want to do, and I'm so thankful to be here. And I'm gonna give you 2 more seconds of why it matters. When we took a look at our population of mothers, we have approximately 25% developed gestational diabetes. Um, that is higher than the national average, which is approximately 10%. And you're also looking at a Medicaid population, which is 50% of our pregnant mothers. So a huge part of our underserved population, in terms of mothers, are at risk of developing gestational diabetes and later on diabetes. So something there to my heart, and look forward for us to keep talking. So I guess I'll hand this over to Rachel to introduce
Oh,
our next speaker.
thanks, Carl. I appreciate you. I'll take it back for a minute, but yes, Rachel, we want you to go next. Rachel Coy is our another partner as part of like bringing the food sector into this conversation. Rachel Coy serves as the Chief Impact Officer at Feeding Texas, and again, thank you for the collaboration and everything you do. Rachel, on to you.
Thank y'all. Yeah. So grateful again that to be brought into this conversation. We know that if we have a conversation about diabetes, you can't have that conversation without talking about food, right? And especially in Texas, we know as food banks, when we survey our households, half of them have someone at home with diabetes. And so we know and have grown as a network of food banks in our understanding that food banks need to nourish our communities and have a high commitment for being part of the efforts in the community to support health. Yes, like y'all said, I'm Rachel, Chief Impact Officer, and we represent the 20 food banks in Texas. And I just put a link to the map of our network, because oftentimes the number one question I get is which food bank is in my area, and so there you go. And before I introduce Jasmine, I wanted to just highlight a few things about food banking in the 21st century that may be new to some of you, was new to me when I stepped in my role 10 years ago. One of the most important things about food banks, again, I mentioned, is our kind of renewed commitment to health over the last 10 years. Something really amazing about the Texas Food Bank Network is about half of our inventory is actually produce. And that is not done by chance. It's that over the last 10 years, there's been a huge commitment in our network to build the warehouses and the refrigeration and the logistics and the sourcing to get produce to our warehouses. And so I think, that has been a big focus of our network. And so I just want to let y'all know that if you were to visit a food bank today, and the food pantry network, there's going to be a lot more produce, both fresh and frozen or canned or dried, that supports the health of our what we call neighbors or our members or community members. The other thing that I'll say is that, Houston is the largest food bank in the nation, and so I'm so grateful that they can be there to speak to their expertise. One of the things that is not unique to our network is just the way that food is distributed through food banks to communities. And so many of y'all may have been either donating to your local food bank or have at one point volunteered at your food bank. And so you'll know that the food bank is really like a huge big logistical warehouse in your region. And it works in donors and corporate partners and grocery stores are all providing food to the food bank. Food banks also purchase a lot of food to round out their supply, and that is distributed through a fleet of 18-wheelers and drivers that then provide food to local pantries and soup kitchens, community centers, even pantries in schools. And so just wanted to share a little bit about what food banks are and the network of agencies and food pantries that they represent. But a little bit about Jasmine. Again, Houston Food Bank does so much. They do medically tailored meals. They have lots of different healthcare partnerships, not only in the Houston area, but just generally in the Gulf Coast area. And Jasmine and her team are at the center of a lot of it. Not only supporting healthy distribution, but doing nutrition education classes, and then working with various healthcare partners, whether it be on the plan side or on the healthcare delivery side, to connect community members to resources and food. And so I'll just hand it to Jasmine to introduce herself real quick before bringing it back to the group.
Thank you so much. And hi, everyone. I'm excited to be here, and I'm looking at tons of screens, but know that I'm fully engaged. So I'm Jasmine Lehner. I am the Nutrition and Partnership Senior Manager at the Houston Food Bank, and I oversee our community health department. So that includes an array of programs, frameworks, and food, as well as food as medicine and nutrition education. And I would say, really, this is like a full circle moment. I'm a dietitian as well by trade, and became a dietitian because my mom is diabetic. And when she was diagnosed, she was like, what do I do? So I would say she now has her own personal dietitian that reads the labels with her. We go through the grocery store, and she has a better sense of how to manage it with food. So this is a full circle moment for me, and I appreciate to be a panel on this presentation day today. So thank you.
Thank you, Rachel. Thank you, Jasmine. It's truly an honor to have you all join, and again appreciate the work you and our plans and many partners across Texas do every day. So I'm excited to continue having this discussion. Jasmine, if it's okay, I would ask you to go first, and then Carl, I want to go to you next. Given the participants joining us for today's discussion and the many different sectors and perspectives present, everyone may not be familiar with the role food banks have to play within this larger ecosystem of diabetes prevention, and Carl, the same goes for the plans. So I would love for both of you to spend a few minutes to kind of just share largely the food bank system at large. And I know, Rachel, and you briefly spoke to it, but how do you come to this, and how do you view your role and the approach to prevention as a food bank? And then Carl, also would love to hear from you, both for plans, community health plans at large, but also from a Driscoll health plan perspective. How do you view your role within this larger ecosystem and approach to prevention? So Jasmine, go first, and then Carl, I would love for you to share your perspective as well.
Yeah, thank you. And I have some notes that I took. So a lot of individuals do know food banks as an emergency response, and we step up definitely when there's a disaster. However, we have programs that are very specific to address health. So just to provide a very quick overview, we understand that there is a link between food insecurity and overall health. So I would say probably about 10 years ago, the Houston Food Bank embarked on a journey to learn more about this link per se. And we actually have a couple of programs, our nutrition policy that is very integrated. So I do have the ability to share my screen. And just wanted to share with you all a food framework that we have. I'm going to pull it up really quickly. And let me know if you can all see it. Perfect. So this just shows our health strategy at the Houston Food Bank. And just to provide this very quick overview, the basis of our framework or health strategy at the food bank is our food framework, also known as a nutrition policy. So regardless if a neighbor is coming through a program at a pantry, we are ensuring that when food is coming into the food bank, we are ranking the food based off of saturated fat, added sugar, and sodium, and it's ranked there, as well as culturally relevance. We want to ensure that the food that we're sending into neighborhoods are foods that they would consume and that they're familiar with. So again, I was looking here, we have approximately 13.7 adults in Harris County right now living with diabetes. And I'm sure for pre-diabetes, that number is probably doubled. I don't have the data for that. However, again, we just want to make sure that regardless of where you're entering within our system, you'll have access to nutritious food. And then we just have some of our just very specific programs that support individuals. So I will highlight just our FoodRx program. We work with healthcare partners, so healthcare systems, healthcare plans. We had just recently completed a project with Community Health Choice where we were screening individuals for food insecurity. That population was a maternal population plus a condition, so high risk pregnancy, which had different categories, which gestational diabetes was one. And those individuals on the program receive bi-weekly deliveries of fresh foods, protein, as well as staples. So with that program, we were able to provide consistent food access. So that's really one of the big difference when we're looking at programs that specifically to improve health versus your emergency response. We are providing that consistent food access to the neighbors so we can stabilize their condition. So I will pause.
Love it, and I love this visual framework.
Yes, it's something. So yes, I'll pass it on to Dr. Call.
Thanks, Jasmine. Call. What your take?
Hey, thank you. So as a community health plan, so health plan, as mentioned before, we serve South Texas, and in terms of how have we been addressing or looking at addressing social drivers of health, and today is about diabetes and food insecurity, and their food needs, and so it's all part and parcel of that, and so. Very often people associate the health plans as, hey, pay your claims, we pay for medications, but more often than not, what people don't see is a huge part of what we do is about wellness. It's about how do we keep our clients, our patients healthy, well, so that they don't have to have diabetes. They don't have to require expensive medications. We don't have to deal with a lot of the adverse outcomes that we often see. And to me, if we can prevent, for instance, one preterm birth, just because we were able to help a mom manage her diabetes, then it's worth it. And so, in terms of how we're leading that effort, we're doing many things. Some of it are innovative, and some of them are just simple block and tackling. We're doing universal screening for all our moms, all our moms for social drivers of health, food insecurity. Those that we're identifying, we are linking them with resources, not just resources that provide those services, but community organizations within their community, within a few miles of where they live. The food banks are a huge part of that organization and network, and we cannot do it without them. And very often that partnership with the food banks, and the food banks being even within your local community, and those food banks are supplying and very often making sure the food pantries are also stocked. And very often those food pantries are the places where folks access food. We're also looking at we are increasing the number of our children that are being screened for social drivers of health. And just remember, a child represents a family. So even though our children are our members and our clients, they actually represent a family. And part of the Driscoll Health Plan mission is to make sure that not that all our children are well, but also their families. Because without that family, that child can't be well. And so we look at it as a big part of our mission. And so we over the last couple of years through working with a lot of our pediatric practices, our pediatric health homes. We have about 16 of them. We implemented a project, an initiative with them where they did universal screening of all their patients. We didn't care if it was our health plan members or not. It was about transformational change for food insecurity. And we, up to date, we have screened about 75,000 patients for food insecurity. About 14% of them we've identified they had food need, and we did one step better. We provided those practices with QR codes. We actually had our resource coordinators work to identify who were the community organizations around them, around that practice, so that they gave resources to those folks that were tailored to them, that was patient-centered. And so that's been a big push in terms of the health plan. How do we come up with solutions that involve our community partners? How do we and the food banks are huge community partners for us, but also about that community outreach. We've partnered with over 500 community organizations within our 24 counties, and it goes from county to city to neighborhood. And I think that's what a community health plan brings, is that we bring a lot of that knowledge of what's happening at the community and at the neighborhood level, because our employees actually live in this community. So just very high level in terms of just some of the things of how we are doing trying to do things to improve wellness, to prevent diabetes, to be addressing obesity, but also somebody who does have diabetes, how do we help them help themselves?
So wonderful. And there is so much to unpack here, but I want to kind of pick on a few things that you spoke to, just in terms of recognizing is this emphasis on wellness, which is so central to prevention focused efforts and conversation. And then again, like this broader lens of, it's not just the child as your patient, but it's the linkage to their family and then in turn to the community. So really appreciate that. Carl, if I'll stick to you, and then I'll go to Jasmine. You shared it in your introduction in terms of this unique region you all serve, like 24 counties, which for those of you not familiar with the landscape, it starts somewhere in that starts in Corpus Christi and the surrounding counties and goes all the way, stretches pretty much the expanse of the valley and onto the west side, which is a good mix of border counties, rural counties, urban counties, and everything in between. On that, you layer uninsured population, non-English speaking or non-fluent populations, and transportation, and so on and so forth. Innovation and transformation is deeply contextual and has a nuance. Given the population you serve, and you may have more layers to describe the nuance of the communities you all serve. And given those contexts, how have you approached innovation or efforts around prevention that have been unique to your community?
Yeah, good. Thank you. You did a fantastic job kind of highlighting our area of coverage. I often tell people those 24 counties are the equivalent of the size of South Carolina in terms of area, and the vast majority are rural. Some of those counties actually have more cows than they have people. And then a large part of our population sits along the U.S.-Mexico border, from Eagle Pass, Laredo, McAllen, Bronxville, Harlingen. So it brings with it its own dynamic, and a big part of our population is Hispanic. So Driscoll Health Plan. So in terms of one year we went in terms of innovation is our nurture program. So our nurture program really came out of us looking at our data, and I think got mentioned it before, where we saw such a high rate of gestational diabetes with our maternal population, and the health plan is the largest Medicaid health plan provider for pregnant women in the South Texas region. And we said, what could we do different how could we leverage addressing food insecurity? And so we came with a nurture program, and we partnered with folks like Episcopal Health Foundation, Factor Health with Dell, and our grocery chains and food banks, and our local community, and also got some grant funding. And so we with the nurture program, we identified mothers who were at high risk of developing gestational diabetes. So so when we did a kind of a randomized look, and when we asked those to enroll, it was women over 30. It was between October 22 to July 23. And why did we pick women over 30? Because they were even at higher risk for developing gestational diabetes. 1 in 3 would develop gestational diabetes. So because we wanted to do something at the beginning of their pregnancy, not when we found out that they had diabetes. And this was really about prevention and to see if we had an impact. And if they enrolled, we, besides our regular case management that we would offer, we offered them grocery cards to the amount of $40 a month. We also offered nutritional counseling. It was totally optional. 89% of our moms took up that offer of nutritional counseling, where that nutritional counselor would work on a dietary plan for that mom. So hey, not only can we get you food, but how can you best utilize the food? And they had the option to do a second consult, and 84% of those moms actually chose to do a second consult. We provided every month we sent packages with recipes, be it in Spanish or English. We offered them tips from Brighter Bites, also whether it be in English or Spanish. And most of this was managed by our community health workers with the health plan. And so we actually had a total of, we looked at a total of over 1,200 pregnancies, and we kind of followed them through their pregnancy and after they delivered to kind of see how they did. So we continued that support throughout this. And the whole idea of this was two things. One, give them the resources that they needed so that they could get the healthy foods or access to healthy foods. Two, give them the skills and the knowledge to how to best use it. And some people says, hey, why did you all do grocery cards? And so the answer is we wanted moms to feel that they had control. We wanted it to be person-centered, and we also recognize that moms very often would put their families before themselves. And so if we did not feed or find a way to feed the family, then a lot of our effort would probably not going to be as impactful. And so we felt this at the time, we felt that this was going to be probably the best way to do it, but we also wanted to see if we made something like this part of one of our value-added services, but how big of an impact it would have. And what we found was that, as we took a look, we didn't expect it to make a difference as how many moms developed gestational diabetes, and it didn't. But what we saw was a huge amount of engagement. Nearly 99% of the moms that we offered this program to said yes. So this is something they want. This is something that they need. Two, when we took a look at those grocery cards, how much, they spent the vast majority of it, almost 97% of it. And so it did not go unused. When we took a look at outcomes, we were surprised by some of the results we saw. We actually saw a 6.5% decrease in C-sections. That was not something we were really expecting. You say, why would this happen? I mean, how does me addressing food insecurity affect C-sections? And we're not really clear, but what we do think has happened, because we had such a high engagement of moms, and because we were doing something that addressed their families, that it increased their trust with the health plan, but also it increased their engagement with the health plan or case managers, and increased engagement and trust with their healthcare providers. Because that's the only way I could see how that's affected those C-section rates. We saw preterm delivery rates fall by 4% from 17 to 13% for that study when compared to the control group. And then when we took a look at cost savings, we had cost savings because we had more vaginal deliveries versus C-sections. We had a significant decrease in delivery costs. but because those babies were now being born vaginally, and we had a lower preterm birth rate, we saw decreased newborn um, costs associated with them. And so we, based upon our study, we actually saw that, we were saving a little over $1,700 per mother per delivery in those that got the intervention, meaning just something as small as $40. With the addition of nutrition, um, counseling, support, and addressing the other drivers of health, had a big impact on moms accessing the healthcare system, moms trusting their healthcare providers, and having positive effects in terms of birth outcomes. So again, it wasn't in ways that we expected to see, but it was huge in terms of, the learning that we came out of this. And so this is going to help us to develop new innovations and new strategies to deliver food, and very much in concert with our community partners like the food banks. And to me, this is what innovation looks like. Not to be afraid to fail, not to be able to, but also to kind of do things differently than how people have done them before. And so we look forward to doing a lot more of that. And I think this is where, being a community health plan, we're not afraid to do those things because we're listening to our community partners and to our clients. And I'll say one more thing before I hand it back to you, Ankit, and that is, as we develop this intervention, not where we've just given them grocery cards, but we were also looking to make sure that wherever they were, they had access to a grocery, because that's going to be the other aspect of dealing with food insecurity is, do they have access to that food, be it a food bank, be it a grocery, and so that was and if they didn't, we provided the transportation for them to get there. So and we gave them the option for home delivery. So it wasn't just about addressing food insecurity; it was also about that modality in terms of how the moms accessed food. And I think that's a big thing of what the food banks are also doing. So I just gave a good example of our nurture program and some of the things that we're doing, that I think has a huge potential, a positive impact. And I think there are lots of studies that are now coming out that are showing that by addressing that food insecurity, and that we are making an impact for folks with diabetes, either better diabetes control with the HbA1c, or very often it's about their quality of life. It's about them eating more healthily, using more produce and fresh vegetables. But more often it's about engagement. And we need engagement of patients and families in their care, and they felt more in control of their care, that for us to see those positive outcomes. So it's beyond just medications. It's now about self-motivation. It's about empowerment, and it's about being person-centered. So I'll hand this over to you, Ankit.
Thank you, Carl. Again, I appreciate, and there is so much here, but I think you have expanded the scope of conversation. That when we talk about diabetes prevention, like for example, you spoke to the cost effectiveness or the ROI, and which is not just around like the savings you are going to see on the diabetes care side or treatment side cost prevented, but essentially the impact it's going to have on other health needs and cost drivers, as well as again, this renewed emphasis on that when you're engaging, in your case, with moms, you're having the ability to impact the broader family, and it's kind of the transformative impact you are going to have in that, which is really exciting. I also appreciated both your intention, which speaks to the nuance around the innovation, that many of the families you're trying to address this needs around nutrition, they are also probably dealing with other barriers, such as access or transportation and so on and so forth. So your agility there is a key. So again, I appreciate that. Jasmine, I wouldn't say that because Houston is urban that your challenges may not be the same, but they just have a different nuance. Again, Rachel shared the largest food bank in the country, which is amazing, and appreciate all that you do. But comes with that challenges around meeting the needs of the many Houstonians, and I would say beyond, the residents and community members that you serve. And again, taking that into account, how have you approached your innovation and efforts around this space in terms of the nuances or the considerations you have had to either account for in terms of your planning or during implementation you have learned that has led to some refinements?
Yeah, thank you. I would say specifically that the Houston Food Bank, we also cover a total of 18 counties. And I know the visual that Rachel shared, it shows some of the counties that we support. Specifically within the kind of food as medicine programs or community health, we see an array, a different variety of patients, specifically Hispanic, Latinx, African American, but also seniors as well. But we also have a couple of partners that address pediatrics, which we've seen that all of the different populations that I just named either have developed some sorts of diabetes or have a greater risk of developing. So for us, specifically with our food prescription program, we are working with healthcare partners to integrate food insecurity screeners into their workflow. And plus targeting on a specific condition. So we have a lot of healthcare partners that focus specifically on diabetes. So they're screening individuals for food insecurity, plus maybe an elevated A1C of 7. So again, the purpose of the program is that we're providing consistent food access over time. And that's also paired with nutrition education. So we have a team of nutrition educators that provide education either with our healthcare partners. We host virtual classes, and everyone that's also enrolled into those programs, they receive an email that releases bi-weekly education available both in English and Spanish, very short videos, but it goes into why do we eat? And it really highlights that we eat for different reasons, for budgets, for preference, for cultural. And we really like to tie in that nutrition education. It's more than, yes, reading a nutrition fact label, but to know that your cultural food matters. Or if you don't have enough time, this is how we can work with what you have and time management specifically. One of the things that I would truly love to highlight is we have a community engagement department, which is also led by a dietitian here at the food bank, and they sit with our community, not only the neighbors that have lived experience, but also the partners that we work with. And we're really able to sit at the table and actually tailor programs or revise programs with the community in mind and alongside the community. So I think for so many years, many food banks were, serving the community to address needs. And now we're moving to a place where we're sitting in community and really understanding our neighbors to meet them where they are. Specifically. So being able to receive information directly from neighbors is how we're able to approach some of the ways that we implement the programs that we have at the food bank. So that has been very neat for me as we're seeing some of those changes that are neighbor focused. And I would say just to kind of also elevate with specifically in mind diabetes. Again, we have individuals that are impacted by diabetes, so we can tailor our nutrition education that really focuses on diabetic-friendly foods, how to read labels. When we're working with our partners, them understanding the importance that 50% of the food that we distribute should be nutritious, should be produce, and then what goes along with that. So again, we also have a team that really goes out and works with our pantries, and we have a healthy pantry network where we're providing this nutrition education to our partners. So we're changing the environment of the pantries. We have shelving signs that talks about what's low sodium, why is this food diabetic friendly. So we're really changing the environment of the pantries that we have because they play a major role in providing that food access. I think Rachel mentioned it. We're kind of like a huge warehouse but the partners that are with the actual community, they're the ones that's working with them every day. So being able to have that direct feedback from both neighbors and partners have been vital to how we implement programming.
Wonderful, Jasmine. Thank you. Before I ask the follow-up question, I just want to have a reminder for our participants. Again, thank you for joining. We will be taking questions towards the end. I see a couple that are already there, but I would invite and encourage everyone to include your questions in the Q&A option. And in a few, we'll be coming to answering some of those. But Jasmine, again, one of like there is I had an appreciation about the community that you have a large population to serve, but now I'm beginning to appreciate what does it mean when you say 14 counties. And then as you were speaking, the takeaway is that there is not a one size fits all approach. It's really kind of unique to each individual, not just this many communities you all serve. But you have managed to serve at this scale. So as I think about innovation, and Carl, I want to come back to you for your perspective. But Jasmine, if I can begin with you first, is what are some perspectives, lessons, best practices you have to offer from your experience that can allow other food banks and the many different partners you all work with to kind of look at this from a scale perspective, that they could be doing this across all communities in Texas? So, Jasmine, if you can share first, and then Carl, I would love to hear your perspectives as well.
Sure. I would say for us, trusted partners is the reason we can scale. Excuse me. We have a lot of healthcare partners that we're working with that are integrating food insecurity screeners into their workflows. And I think Dr. Carl mentioned that just really helps build trust between the provider and the neighbor, that they're engaging more than just that healthcare aspect. So for us, we have a team that provides food insecurity trainings where we can offer CEUs right now just for community health workers and school administrators. But as we begin to embark on really highlighting the work that we do, we just noticed that having trusted partners, specifically the healthcare, can really help us scale the programs, because once we can inform them of the impact of food insecurity, which many already they know, they're coming to us as a very great bi-directional relationship. We're just providing some of those tools. And on the community side, again, trusted partners. So we have a network here at the Houston Food Bank of approximately 1,600 partners, your traditional pantries, schools, healthcare, and ensuring that they have all the resources that they need to provide access to the neighbors that may come from healthcare or come from higher ed. Again, they're typically the first faces that our neighbors with food insecurity plus a condition that are seeing. So we want to make sure that they have what they need, if it's shelving, if it's refrigeration. So I would say that trusted partner really helps us on both end, healthcare provider and our pantry network, to really scale the programs that we have.
Love it, Jasmine. Appreciate that. Carl, any thoughts from your vantage point?
Well, I think scalability is always on our mind. I think whatever kind of initiative we do, be it a pilot or like what we did with the nurture program, a lot of it was very much like a pilot, was a big part on what kind of helped help us decide on what we did was about scalability. How much available resources, be it a health plan, be it a community has, but also about reach, right? How can we reach as many as possible? And one of the biggest barriers that we see in terms of scalability is about food delivery or food access, meaning, and I kind of alluded to it, and I keep coming back to it because it is going to be probably one of the ways that we innovate as we address the food insecurity. We're talking about diabetes today, and be it somebody, be it a population that we identify as being at risk for diabetes or already has diabetes. saying, hey, this is where you go for food is not enough. How we innovate and scale is going to be how do we bring that food closer to the patient, the member, the client, right? And I think the food bank's been doing a fantastic job. And so that means as we scale, we need to have a kind of like a repertoire or a toolkit of different ways that we can bring food to the person. Secondly, as we scale and innovate, we have to make sure that whatever we're doing is culturally appropriate, meaning I could give you all kinds of great food, but if this is not something that's not familiar to you culturally, you don't know how to cook, um, then it's not going to get used, right? And so I think the food banks have done a really fantastic job there too, because they know their communities. It's not just about, hey, I'm providing you food. They know their communities and they understand the culture. And I will tell you, I can go from Bronxville, Harlingen to Laredo to McAllen, and it's all very different, right? In very good ways, right? And or Corpus Christi or Victoria. These are my areas, or Eagle Pass. It's all very different. And so how do you, to scale, you also have to have some amount of situational knowledge of your community, and to be able to be agile, to allow some amount of customization to do that, right? And so to me, it's about picking the right partners. It's about picking the right partners who can do that for you, that still has the same mission, that have the capabilities to do what you're asking them to do, but also have the capability to to get that to know the landscape that they're serving, versus somebody who's trying to do something in a very big way, but don't have that situational intelligence or that knowledge on the ground. And I think this is where food banks are huge in terms of not only do they provide the access, the resources, they work with partners to provide the access, and they also clearly understand their population. So as we address diabetes, and then the final part is going to be, as we scale, we have to include nutritional counseling. So food is important. Access to food is important. So as we address diabetes, it's not just about food, it's also very often obesity is going alongside with it. It's about the right kind of foods. And so we have to include nutritional counseling. That's part of it. And so whatever we do, whatever model we do, and we try to scale, we have to include nutritional counseling and support, because it's not just about giving them the resources, it's about giving them and helping them get the skills to take care better of themselves, but also about their families and their loved ones.
Call. I think again the cross-cutting themes is agility, partnerships, intentionality in terms of like knowing who you are helping, and the environment that you are helping them within are some of the cross-cutting themes. But again, you all have shared so much insights that I think speak to the many nuances, and again appreciate what you both and your organizations and your partners are doing. Jasmine, to your point, I think is a follow-up conversation, and I think you're reading my mind. Is so I shared in the opening, right, that there are needs, there are challenges in addressing these needs that you both have spoken to at length, but we are also kind of seeing some momentum and shift in terms of the broader environment that is helping catalyze or advance some of these efforts. So would love to hear, Jasmine, your thoughts, like especially like things that have happened outside of the food bank that have helped you kind of do this well, or kind of give you the flexibility to innovate. Also, if you want, you can speak to the few things I shared early on around HB 26 passage, or the ideas available or opportunities available through the Rural Health Transformation Program, and how that can come to bear in Texas, or even like the current administration priorities. And so again, both what has already happened or what's coming up. And Jasmine, if you want to go first, and then Carl, would love to hear your thoughts.
Yeah, and I dropped it in the chat as an area that would be very crucial for scalability for the Houston Food Bank. I know specifically is technology. Specifically, if we had, and in my perfect world, if we had a system that was very integrated with all the different entities that touch a neighbor or touches a neighbor. And really, I'm thinking from a neighbor perspective, they're providing the food bank this information, then they're providing their healthcare partner, then they're providing their healthcare plan, then they're going to housing. And if we had a system that where we could have their information so we could kind of skip past that part and really understand the needs of that neighbor. I mean, outside of food insecurity, we know that being food insecure isn't just a silo. They may be also impacted by housing or transportation instability. So for me, I think it's kind of a two-parter. Learning that having technology that is seamless and integrated is really going to be key just to make this process easier for the neighbor. And then policy advancements. I know recently, and there's always so many numbers, but HB 15775, where the healthcare plans were screening for food insecurity and other social determinants of health. When I was reading that report, the wheels were turning. I'm like, there's so much we could do. And to see HB 26 pass, I think we're on the right track of being able to really just put the pieces together. I think for me, I feel like we're moving too slow, but we'll get there. And I'm sure others feel that way. But to me, technology and policy will really play a really big role in the work that we do.
Jasmine, Carl, your thoughts?
Man, Jasmine stimulated a lot of thoughts in my head as she started talking there. And I would tell you, I think so for HB 26, I think it's been something that it doesn't go far enough, but it is the place that I think we're going to. It says now that Texas, we're going to look at in lieu of services to look at nutritional support, nutritional counseling, tailored meals as we address at-risk populations. And this is something we've been wanting for a long time. But that also means that we get to do some pilot. We get to do a pilot. We get to kind of build upon some of the lessons we've already learned. And I agree with Jasmine, it's not moving as fast as I would love to see it, but we're definitely moving in the right direction. And I think the food banks are well positioned to be one of those providers in lieu of service. I think they're well positioned as we look at the rural transformation because they are very often helping the food pantries in those very rural communities. And to Jasmine's point, they're also well positioned to be hubs. It's like some other community-based community partners where it's not just about a person who has food insecurity usually doesn't just have one need, right? It's usually a multiple of needs because very often they're low income or underserved. And so you actually do need a place where you can get that interconnectedness and somebody who knows how to help you. And technology is one way to do some of that. But I also think a lot of that innovation that we need to do needs to actually come from the people, the people that are very often on the front lines. And that has been my experience, is that those ideas in terms of how we leverage technology, how we leverage relationships, how we leverage the needs comes from within those communities. And I think that's where community health plans, we bring something, a big part to the table. Because as we do some collaborative to address with HB 26 with nutritional support and with rural transformation, you need the payers there to kind of work very closely with your community organizations, with the providers, for this to be effective. And I mean, there's so much we could be talking about. We don't have enough time, but absolutely, I love where Jasmine came from because she took the words out of my mouth. This is definitely where places where I think the food banks are very well positioned. And so how do we support them? How do we create a infrastructure where we do not create too much administrative burden on them, but also how do we improve the access of our patients, our diabetic patients, or patients who are at risk of being of diabetes to the nutritional support that they need, but also all the other supportive things that they require.
So well said. I appreciate you both. I have a couple more, but I want to kind of lift up one question that I think has been in our Q&A for a while, and again want to encourage participants to add their questions. This is special for me, just given both our work in leading the Texas Oral Health Coalition, but my own background as a dentist. Given your perspectives, and we have talked really from broader healthcare perspective. And again, Carl, one of your early comments on wellness, where do you see a role for bringing in the oral health community? And I would say, again, like this is a whole health, and you have already spoken to the holistic, but if you have any nuances around like bringing in your community partners or perspectives within the oral health space, and as an extension of that, even in the behavioral health and other healthcare needs, anything that you want to lift up in terms of either an opportunity or a role that these professionals and sectors could be playing would be great to hear. And again, this is a question for both of you.
I'll go first, and Ankit, I also say oral health is a big part of what what we support. No, for those not familiar with Texas Medicaid, the oral health and the oral health and the medical health are separated in terms of the managed care organizations. You got the dental medical organizations, and you got the the MCOs. So, unfortunately, some of that has created some barriers between, incorporating both, because oral health is super important. Because if you don't have good oral health, then that affects what kind of foods you can eat, what kinds of nutrition you can access. So if you're not addressing oral health, then you're not also addressing the nutritional health. I think at Driscoll Health Plan, we actually have a dental director who I think is working closely with your coalition, and I will tell you, he has opened our eyes in so many ways. I can tell you some of the stories that she has told us in terms of, the children and adults that she took care of, or open our eyes so much that this is something that we also need to be incorporating. And very often we forget about it because we're so very, we've got our blinders on. So I'm glad you raised that, and I do think that's going to be something that we are looking at. How do we incorporate that as we provide that nutritional support, that it is also an opportunity to address oral health for reduction of dental caries, for especially in our pediatric population. And if you know Dr. Peterson, that's one of her, her big things. So I'll pass it over to Jasmine, but absolutely, I think we are definitely thinking of ways that we can incorporate and improve oral health as we attempt to deliver more nutritious food to our folks with pre-diabetes and diabetes.
Thanks, Carl. Jasmine?
Thank you. In the past, we've worked with many dentist office, really just to provide them with food insecurity trainings, really just to kind of provide an overview of food insecurity that may have happened in their neighborhoods that they serve, the individuals. So I think that was the first step, getting curious, understanding what your food bank has to offer in the area. And I would say continue to be curious. Do you see correlation of increased cavities with individuals that may be food insecure? And could this be something that your team can integrate food insecurity screeners? Because it doesn't mean that you have to do a full-fledged food program, but you can refer your neighbors or your members to the nearest food pantry buy. And it could be a card that you have at the front desk, or integrating some type of information that you can provide to your neighbor. So I would say get with your local food bank, see what programs they have available. I'm not moving enough apparently at my office, which I need to get up. My watch told me as well. But yes, I would say get curious, get with your local food banks, learn about the programs that they have available, and see how you can play a role.
Thanks, Jasmine and Carl, both encouraging. I would again, Carl, probably that's the next conversation we should be having in terms of the linkages and just the broader opportunity. So encouraged with both of your responses, but again, like it starts with us kind of taking an initiative, having a conversation, and there is both the need and the opportunity seen on both sides. So I appreciate the optimism and the direction you both are pointing towards. While I'm waiting on questions, as I said, like I had a couple more, so I'm going to continue. Um, and probably this is more in terms of forward looking and inspiring, if I may, is as we this is an ongoing body of work, and again the needs are many. We will continue kind of like being in this space of learning, exchange, collaboration, and how do we collectively move this work and this efforts forward. So as part of that, if we were to reconvene as a group in say in a year or two, from both of your perspectives, what is one big change you would like to see in how Texas approaches diabetes prevention through food and nutrition? Either of you can go first.
Wow, that's it could be a very big wish list, Kit.
Doesn't cost.
The answer is in a year's time we'll be facing the legislature again.
Yes.
And I personally would like us to say we have learned some things from HB 26 in terms of the pilot in lieu of services, where we can get much more expansive policy and legislation that expands our ability to go beyond just tailored meals, to go to making, putting nutrition and food insecurity and some of these other social drivers of health more on the front burner, that and that we're bringing in some other partners. And it can't just sit in the MCO world or the managed care world. It really is about how do we support a slew of partners. So that would be my wish list. That would be my hope, is that we can get we can start moving. It's probably going to be much slower than that, but incrementally we're moving forward with some legislative that continue to support our mission.
Love it.
Thank you. I would agree. I've been thinking about this question for a couple of days, and honestly, I think I would love to see conversations like this actually turn into implementation. We're all in the room together. So how do we continue the conversation? Who's the container? How do we identify who's missing for us to really come from a cohesive standpoint? Oftentimes when we're planning, we're not thinking of MCO's capability, vice versa. So really understanding how we could come together and then be able to really come up with a cohesive solution that would really support that neighborhood as a whole.
Jasmine, sincerely appreciate that. Also, Carl, I appreciate both your balance between optimism and realism there. But Jasmine, to your point, I don't know if it was a cue, but as part of again our role as an independent public health institute and being the convener, if there is, it goes without saying, I'm committed, and the institute is committed to playing the part in many ways, or in as many ways as we need to. But and truly the efforts you all lead is the inspiration that keeps us going. So I appreciate both of you. I see a couple of questions that are now in the Q&A. The first one is again an applause for both of you for what you do and the perspectives you have brought today. I'll specifically jump to the question part of this comment, is that what are one or two practical steps can we take together as providers, community organizations, managed care organizations to ensure access to healthy food and improve nutrition quality for our community? And the context is just this conversation around ultra-processed food systemic barriers that are driving this outcome. So
I would say, we are still in the early stages of screening. So I think it begins there, because I think I don't think enough of our providers are screening, right? And all my conversation with a lot of the pediatricians and docs are, I don't want to screen something and find out I find out, hey, that somebody needs food, and then now what do I, what do I do? Do I just feed them the paper that I use to screen them with? So I think, but screening is probably one of the first things that we need to do to show that there is a need, right? And so I think there is still a lot of opportunity there for us to encourage, reimburse, create some system things where we have that screening happening at the sites that folks are getting their care, right? And because once that starts happening, then we are forced to do the next step, which is how do I link that person with services that they need, right? That forces their folks' hands to find another partner. It could be an MCO. Usually they're looking for somebody to help them. It could be a food bank, like folks in like that Food as Medicine, which was done by the San Francisco Health Department, where they co-located the food bank or the food resources with the providers, with the community health centers, for instance. So to me, that spurs action, right? That spurs innovation. So to me, if I was to pick one thing, that would be kind of like the one thing that I would be continuing to push and advocate for.
I wholeheartedly agree. Food insecurity screeners into the workflow is vital. If you don't know an individual is impacted by food insecurity, then I think that would be a start. I would say to add on, specifically here at the Houston Food Bank, we're also connecting families not only to immediate food access, but we have excuse me, individuals that support families with federal benefits. So SNAP is one of the greatest defenders of food insecurity, although we know it doesn't cover their full household. Pairing SNAP, or formerly known as food stamps, plus that nutrition education can really help someone take a turn. And coming from a dietitian perspective, we never want to come off as the food police, which I'm sure we do, but we want to meet individuals where they are and really focus on one area. When people have a tremendous lifestyle change, piling on too much information can cause someone to retreat. So when we're thinking about, ultra processed, or it's like, how can we increase fruit and vegetables in your lunch? So really just those small conversations and really understanding what a person has access to. I remember one of my first jobs, I was talking with someone and they didn't even have a stove, like a full working stove. So I had to reevaluate how I provided my education based on that person.
Love it. If I may summarize, a few things that you all have spoken to so far is just this intentionality meeting where they are at, and again, you both lifted up the cultural aspects, the geographic considerations, and kind of connecting the dots. I think Carl, you said it in one of your earlier responses. So it's not just the access part; it's the affordability part and also acceptability part for the patient and so on. So I appreciate this. I know we are coming up on time. I see two questions. One, I think, is an answer that you all have spoken to, is that there are opportunities to, again, in the hope or in the pursuit of awareness and prevention around diabetes, like using opportunities with the primary care and closing the gap with the dental visits. Could be one idea, and I think it's more of a suggestion. But if you all have any reaction, and just in the interest of time, I'm going to throw one more in, like about a collaboration between school districts and the food bank that maybe Jasmine you can take in terms of the amounts of packed untouched food that goes in school cafeteria or doesn't go is unused. And how can some solutions or opportunities exist thereof? So again, Jasmine, if you want to give a quick reaction on the school and food, and then Carl, if you want to speak to primary care and oral health and some opportunities. Jasmine, want to go first?
Yes. Well, your luck. Before I was in food banking, I was in school districts. So I would say one of the biggest things, specifically starting with food waste at school, is education. Being able, I actually was in Comal, which is in New Braunfels, and so really speaking with the students about their choices. Sometimes we would have some of our, workers saying, "Get your 2 fruits and vegetables," and they not understand that you don't have to take everything that you don't want. So really, I think that was our first step when it comes to food waste is getting what you need and ensuring. I'm trying not to take too much time, but another area that we tried to do with our families, if they qualified for school lunch or vice versa, if they had SNAP, we tried to get also the families on school lunch as well. The free and reduced program, just to address the food insecurity space, but to address your food waste, it really starts with education, knowing what you can put on your tray, and you don't have to take the milk if you don't need it, although it has your vitamin D and calcium. What could you grab? Could you get yogurt as well? So just try to answer that super quickly.
Thank you, Jasmine. And Carl, any quick reaction or comment on the oral health primary care?
Oh, oral health primary care needs to be part of it, and not docs don't get enough education on it. That's number one. Number two, I don't think the medical community appreciates the impact it has in terms of quality of life, in terms of its other health issues. I can tell you what we're doing at the health plan. And again, I can thank my dental director. We are now screening everybody screening everybody for oral health. And so if we're identifying risk factors, we're getting them back in front of their primary care docs to make the necessary referrals to the dentist. We have done a lot of outreach to our primary care providers, showing them how to do their own screening, providing them with toolkits, but also trying to get them certified to do the fluoride varnish, recognizing this is super easy, do it with their teeth steps, do it with their well visits. And as part of this is getting that child linked up early with their primary care, with their dentist, with their dental home. And so we have been pushing very hard with our primary care folks to be emphasizing oral health, emphasizing going to their dentist as part of being healthy, not just their vaccinations and their developmental exams. But it's also about healthy foods. And again, this whole webinar today is about diabetes and food. And the answer is, you and I both know that most dental caries, for instance, in children, has to do with the use of bottles. So it is about that counseling, what types of foods that they use, reducing the amount of sugar not recognizing the amount of juice, for instance, that folks consume contribute significantly to dental caries. Acid, sticky, and sweet are all the enemies of teeth, right? Hey, I just did a rhyme right there. So I do think that as this is going to be very important in primary care, but it also bleeds over definitely in terms of how we address the food insecurity in our diabetic population. How do we not only get them healthy foods and culturally appropriate foods, but also give them the skills in terms of how best to use those foods, and they're ready to accept it, right? If they're not ready to accept it, all the work you do is not gonna bring fruition.
Thanks, Carl. I appreciate the rhymes and again the connection here. I know we are a few minutes over, but appreciate everyone staying through. And again, I sincerely appreciate Carl for you and everything you do through Driscoll Health Plan, as well as Jasmine for everything you do through the Houston Food Bank. Again, appreciate our partners at the Texas Association of Community Health Plans and Feeding Texas for this discussion. Please fill out the evaluation to share your insights and how can we continue to do more of this sort of learning opportunities and exchange, as well as insights you have on topics. Again, on behalf of the Texas Health Institute team and our partners at TACHP and Feeding Texas, thank you for joining us today and everything you do to make Texas healthy. Thank you.